we'll shift to the next speaker, Dr. Ahmed Ashour. He is a lecturer at the Oncology department. He will talk on the upfront use of Rituximab in pediatric non-Hodgkin lymphoma, Alexandria University experience.
For this event, and congratulations for this very successful meeting. I will speak about the upfront Rituximab in pediatric non-Hodgkin lymphoma. I have nothing to disclose related to this presentation. As we know, non-Hodgkin lymphoma account from 6 to 8% of all malignancy in pediatric age less than 19 years old. And if we're looking for survival, first in the SEER data from 1975 to 2007, we found the survival extend from 50% up to now 80% for non-Hodgkin lymphoma. And also there is more than 100 different non-Hodgkin lymphoma depend on a clinical presentation, morphology, immunophenotype, cytogenetic and molecular biology. But this data published in Hematology, the most common type for aggressive non-Hodgkin lymphoma in pediatric is Burkitt, lymphoblastic, diffuse large B-cell, and anaplastic large cell lymphoma. And another data from the SEER shows that the Burkitt lymphoma is the most common, mainly for pediatric less than 14-year-old, followed by lymphoblastic, diffuse large B-cell, and anaplastic large cell lymphoma. As we know, Burkitt lymphoma is a three-type sporadic, endemic, and immune deficiency type. It presented by a mass in the abdomen or head and neck, and it presents in advanced stage with a bone marrow or CNS in a 20 to 25 of the case. This is start is an urgent medical intervention and require diagnosis, staging, and treatment. For Burkitt lymphoma, the immunophenotype is a CD20 positive, CD10 positive, BCL6 positive, BCL2 negative, MIP1 more than 90%. And for cytogenetic translocation, MEC and IGH 80% or MEC IGL 10% with translocation 814 or variant translocation 822 or translocation 28. And recurrent additional abnormality is 1 plus or 13B plus or deletion 17. For diffuse large B-cell lymphoma, immunophenotype is a B-cell variant, CD20, CD22, CD19, and CD79A. Germinal center subtype CD10 positive and absence of BCL2. 5 to 10% of diffuse large B-cell lymphoma can express MEC, and the current cytogenetic abnormality is minus P14, minus 19Q, plus 16P. And there is overlap between Burkitt and diffuse large B-cell lymphoma. In one study, show molecular defined Burkitt lymphoma present in 30% of histologically defined children and adolescents diffuse large B-cell lymphoma. And so they are treatment the same for Burkitt and diffuse large B-cell lymphoma. And treatment depend on initial resection, LDH level, bone marrow, and CNS involvement, early response to the pre-phase. And the principle of the treatment is a short and intensive chemotherapy, fractionated cyclophosphamide, CNS prophylaxis by high-dose methotrexate. And there is a major breakthrough improvement in a management of Burkitt lymphoma in the last 30 years. In 1997, the cure rate for Burkitt lymphoma from 10 to 30%, and now extend up to 90%, up to 90% in 1999. The following 50-year prognostic factor survey to maintain a high cure rate and less acute and delayed complication. Prospective FAB and LAM and PFM study contribute greatly to this improvement. This is a classical LAM protocol. They classify the Burkitt lymphoma into the three different groups, Group A, B, and C. For Group A, they give COBAT for induction, and for Group B, they give a pre-phase induction, consolidation, and maintenance for Group C. For PFM protocol, they stratified according to complete resected for LGH, bone marrow involvement and CNS involvement, and give certain block according to the different group. And this data present on SIOP 2010 shows the event-free survival for both this protocol, nearly for stage 1 and stage 2, 96%, but unfortunately for stage 4, the event-free survival is 80%. So we need additional treatment for high-risk patient with a stage 4. So they think about rituximab. They try to evaluate rituximab efficacy in addition to the standard LAMP chemotherapy regimen in high-risk mature B-cell lymphoma. Of course, there is a mini phase 2 trial before beginning of this data, which combined rituximab with a many different regimen for Burkitt lymphoma. The rituximab is a monoclonal antibody. It acts by the 3 different mechanisms. It can act to the CD20 receptor and leading to activation of natural killer cell and leading to the direct cell lysis. Or it can act to activate the complement pathway and leading to the cell lysis, or can activate the macrophage and the antigen-presenting cell and initiate the cell-mediated immunity, what's called antibody-dependent cellular cytotoxicity. This is the intergroup Rituxan 2010. This is a multi-center trial in 12 countries, also with 292 sites. They randomize the patient to receive the LAMP protocol for Group B and the Group C with or without rituximab. They gave rituximab 6 injections, 2 during induction with COP-ADAM and 1 with CYM for consolidation in the Group B. For Group C, they gave 2 injections with rituximab and COP-ADAM, and consolidation, they gave 1 injection at CYV. The first presentation of this data on November 2015. This presented 147 patients from Europe and 136 from GOG. 155 with rituximab and 155 without rituximab. The patient character, the gender, 83 are male, as regard to the age, 3% less than 3 years, and 55% between 3 and 8, and 33% between 9 and 14, and 10% less than, more than 15. And for histological type, Burkitt account 85%, and diffuse large B-cell lymphoma 8%. And this is a characteristic stage. For stage 3, 45%, and for stage 4, account for 50%. For toxicity profile, the most important toxicity for rituximab is the infusion reaction. It occurs about 1/3 of the patient on the first infusion, and it decreases subsequently with each cycle until it reaches 5% for a 6th infusion. And as regard to the grading of the toxicity, it's mainly grade 1 and 2, and grade 3 are less than 5% for infusion reaction for rituximab. As regard to the death, toxic death, 4 related to infection, 1 to previous surgery, and 1 toxicity to high-dose methotrexate. 2 early, 1 after COP-ADAM 1, and 2 after COP-ADAM 2, and 1 after CYV. 3 in Europe, and 3 in COG, and 3 with rituximab, and 3 without rituximab. Other related toxicity, mainly febrile neutropenia and mucositis. The summary is there's no difference between the 2 arms across the 3 groups except for the rate of febrile neutropenia, which is higher in the rituxan arm, and after the 3rd course of CYM1 or CYV1, 50% versus 34%. Toxic deaths are equal on both groups. The updated result of this trial presented in November 2017. Now there is 362 patients, 180 patients with rituximab and 180 patients without rituximab. Median follow-up 31.5 months, and all patients except 10 have more than 1 year follow-up. The difference in event-free survival between the both groups, the patient with rituximab, the event-free survival is 94.5, and without rituximab is 83.5. This is the same data published by Lab and PFM protocol that present on 2005. And they concluded the 2-year event-free survival is 84% for groups that not receive rituximab versus 85% with hazard ratio 0.29. And so they conclude that rituximab 6-dose plus chemotherapy be the standard treatment for a patient with a high-risk non-Hodgkin lymphoma and Burkitt lymphoma. What about Burj Al Arab University Hospital? Burj Al Arab University Hospital opened on 2018. Before that, the pediatric patient was treated in the Department of Clinical Oncology in Alexandria University. We adopt the protocol of rituximab plus lab protocol for Group B and Group C from 2016. We have average 20 cases per year in 2016 and 17 and 18 for Burkitt and diffuse large B-cell lymphoma. However, when we move to Burj Al Arab, 1/3 of this increased the number of patients by 1/3, by 30%. And for our patient, the age range between 3 and 15, with 2 cases less than 1 year. For gender distribution, 60% are female and 40% are male. And the site mainly abdominal. We have only 4 head and neck sites. And for a group, we have most of our cases are Group B. We have 15 cases are Group C. 5 of them are Burkitt leukemia, and 10 of them are present with bone marrow lymphoma. And on our series, we have 5 dead from neutropenic sepsis, and 3 relapse. 1 of them all are treated with RIs. 1 undergo bone marrow transplantation and under cure. 1 are progressed during RIs, and the other has a good response but delay until bone marrow transplantation and eventually progress. Thank you very much.
Thank you, Dr. Ashour, for the comprehensive presentation. Any questions, please? Okay. If you have one question.
I'm sorry, just may have been a little bit fast. Just to see on your protocol in Alexandria, did you give rituximab to the low-risk patients also, or
No.
No, this is just for the.
This is a statistic. This is why we have a 10% or 10 patient or Group A, but we don't give rituximab for group, just for Group
So
B and C.
only Group B.
Okay, thank you, Dr. Ashour. For the last presentation, it will be my dear colleague, Dr. Mohammed Shazli, will be presenting the concept of biosimilar taken from the rituximab drug to the biosimilar to rituximab. Dr. Shazli, please.
Good evening, ladies and gentlemen. I would like to seize the chance to congratulate Dr. Shadi for his second successful conference. And I would like to bear with me, I don't want to hold you up from dinner, so I would try to be quick. It's kind of boring, but bear with me. So these are my disclosures. This is our agenda for tonight. We'll start by some storytelling. Then we'll talk about what are the biosimilars, why do we need them, and evaluation of the biosimilars, and some newer concepts in this field. The storytelling that we're going to start with is how many patients, all of us, work in public places. And working in a public place in a limited resource company just like Egypt, it hinders our hands behind our back when we're seeing patients and we can deliver the optimum care that we can for these patients. The problem is usually not with the science. The science is progressing, and one of the aspects with the arms of the progression of science is the use of biologics, and it has been there since in the ending of the 90s, I guess. And the problem is that we cannot deliver. The problem is with the price of the development of the newer biological agents. And this problem is that the development, and we'll talk about it in a few minutes. Let me talk to you about the things that we have. We have the American experience with the FDA, and we have the EMEA experience or the EMA experience. We'll talk about both. So the problem is that with the biological agents is that it influences some financial toxicity on the health system that the drugs are being developed and used in. One strategy to reduce that is that trying to have some kind of a generic. And let me be guarded about this concept, and we'll talk about it. Why is it different in a while? There are 23 developed or approved now FDA biosimilars, FDA approved biosimilars in the United States, and around 25 or actually more in the EU. So the problem with the biosimilars is that, as you can see here, is that the US GDP, we'll talk about the United States because they have data which is already mature. Since in the last of the 90s, or the end of the 90s and the beginning of the new millennium, there has been a jump in the cost for the cancer medical care and the cancer drugs. And actually, the top 10 Medicare drugs, which costs are, the 10 drugs, there are only 2 or 3 drugs that we are not using in cancer care. And as you can see in the top 3, in the top 5 disciplines or therapeutic drugs, more than 30% of the spending on the therapeutic drugs is concentrated in the top 5. And the first of them is the oncology. There is a rising cost of cancer drugs. As you can see here, it has been a steady trend of the increase for the cost of cancer drugs that has been there since the 2000. And it is estimated in the global spending that it increases since the 2000 by an enormous amount till 2017, and even the 2019 data is there, and it's higher by like 20 billion more. So biologics, they continue to outpace the overall spending growth and are expected to represent around 20% of the global market value by 2017. And this actually hinders the patient's access to biologic therapy. Why is this? Because it has been steady in the United States. The household income since the 1975 till now, it has been steady. Or even if we take it by purchasing power, it may be less. And actually, the cost, the median monthly cost of new anti-cancer drugs in the United States has been rising since that time that we had specified. So what are the biosimilars? The biosimilars is actually, it's a drug, a biological product that is similar to a US licensed reference biological product for which there are no clinically meaningful difference in safety, purity, or potency of the product. And this is the definition of the FDA. Why is it different from a generic? A generic is usually produced for a chemical compound. So just like the aspirin, we have 180 molecular weight at aspirin with a molecular weight of 180 versus a monoclonal antibody, which is actually 150,000 in the molecular weight. And there is a lot of differences. The chemical compounds, they are small, they have low molecular weight, of course, they are simple, they're well-defined. On the contrary, the monoclonal antibody are large, they are complex, they are heterogeneous. The manufacturing process is actually, for the chemical compounds, is usually done by chemical reactions. On the contrary, the use or the biologic agent or the biosimilar, it's done in living cells or organisms. It's impossible to ensure identical copies, and we'll talk about that in a minute with clinical evidence. They are completely characterized for the chemical compounds. On the other hand, for the monoclonal compound, for the monoclonal antibody, it is impossible to fully characterize the molecule that you are having. The chemical compounds are relatively stable, versus the monoclonal antibodies, they are not stable. They are labile to heat, they are labile to light, some of them. The immunogenicity of the chemical compound, they don't have immunogenicity. On the other hand, the monoclonal have. So the FDA have been developing a process so that it would be able to make sure of the similarity between an originator and the biosimilar applicant. So requirements for the biosimilarity, as you can see, it's a very tedious process. In the analytical process, they have 60 qualiometric parameters that every company which is applying to have a biosimilarity license that has to go through to make sure that this drug is similar to the originator. Then subsequently they go into some non-clinical or animal model trials. Then they go for the PK and PD, the pharmacokinetics and the pharmacodynamics and the immunogenicity, and it's usually done in normal people. And then they have a little bit of clinical data. And this is why the process or the idea of having biosimilar products is easing or lessening the regulations or the process of getting a drug approved, to make sure that the cost of research that has been indicted by the pharmaceutical company is less. So there is actually some concept which is the FDA adopts, which is the totality of the evidence. So they talk about all of these data or all of these steps that all the pharmaceutical applicants, they have to apply to. They have to go through the analytical studies and the animal studies, and then they take the totality of the evidence, all of this to make sure that the molecule, the applicant molecule, is actually similar to the originator drug. And then the extrapolation, even for the extrapolation of the indication, they also have to make sure that they have convincing evidence to support this extrapolation of indication. And it depends, of course, because the indication, sometimes there is an indication of rituximab, like my colleague, Professor Ahmed Ashour has been talking about the rituximab, so it is indicated in the diffuse large B cell, and it is indicated for follicular lymphoma. So he has to have more data, so a rituximab biosimilar has to apply more clinical trials or clinical research or convincing research for the FDA in order to have its approval for the newer indication. And these data may be in the mechanism of action or the PK and PDs or in the toxicity or any other factor. So there are a lot of sources of biological variability that happens with the monoclonal antibodies. So we're talking about in the synthesis process, we have the expression system, the fermentation condition, the purification process, final purity, potency, concentration, packaging, and sterility. Also, there is some kind of temporal drift as we talk about it. With time, there is some changes that can occur, and these changes are actually due to production at different sites or changes in the manufacturing process. So FDA and EMA, they have to monitor everything that could cause drift. Let me tell you that by evidence again. So manufacturers need to be vigilant for any change in the production and must always assume that they can result in clinically significant issues. So this is the other story that we have. So one company was applying for a biosimilar for trastuzumab. And when they were trying to make sure with the antibody-dependent cytotoxicity, so they found out that the biosimilar product was actually running higher antibody-dependent cytotoxicity than the originator drug. And then when they tried to audit the originator drug, they took it back and they found out that the ADCC of the trastuzumab from the EU and the US, from the Herceptin, the EU and the US batches, so there were actually a drift in the batch. So there was a problem, even in the same company, making the same drug in different sites, and they had a drift. And the problem was actually more with the batches that was used in the clinical trial. And when they traced this, and they actually published this in the European Journal of Cancer in 2019, they published a 3 years data or outcome of these patients, and they found out, I'm sorry about the small handwriting that it can be seen, but basically if you can see the red curve and the blue and the yellow, so the red curve is actually the biosimilar drug, and the blue curve is actually the originator drug, and the yellow curve is actually the originator drug which was used in the clinical trials. So the patients actually had a worse event-free survival and a worse overall survival, and it was a problem back then. So immunogenic problems or immunogenicity can change, and it's a concern for all biologics, not just the biosimilars. Even for the same biological agent, it could be a problem. And the consequences could be loss of efficacy or neutralization of the endogenous protein, or even general immune response, which can lead to toxicity or allergic reactions. So FDA guidance regarding the immunogenicity assessment, and there is a comparative parallel design with a head-to-head design, so that to make sure that the drugs have proper immunogenicity that is advertised. And there is a newer designation even after biosimilarity, which is interchangeability. The interchangeability, although no pharmaceutical company has applied for it yet, the designation of interchangeability requires higher standards than the biosimilarity, in which there is same results when you switch or alternate with the reference product. And for this interchangeable biosimilar, it could be substituted without intervention of the provider. But it all has to come back, of course, to the state laws that you are practicing in. The nomenclature of the biosimilar, well, it's very important, of course, because of the pharmacovigilance, and it is divided into two. There is a core name. The core name is a non-proprietary name of the reference product, and then there is a suffix. The suffix is actually a random suffix, except for the third drug, which has been granted its name before this law comes out, and it's sent out for a pharmaceutical company. So biological product is losing patency. The biological products developed that we are using are losing patency, and since then there has been companies or pharmaceutical companies trying to develop biosimilars to them. There is now around 23 FDA approved products, and as you can see in the European Union, much more versus the FDA. This means, or it reflects actually the EMA is actually more relaxed. It has less legislations than the FDA. I do believe we have to adopt more the European experience regarding our situation in the limited resource company. Then we have some concerns when we're practicing. Of course, all of the physicians are skeptical about the efficacy, the safety, the impact on reimbursement when you're working with insurance, and concerned that the use will be forced upon them. Physicians' perception that the cost is the main issue. Strong clinical data will be important for the acceptance. Of course, perception that switching to a biosimilar may not be safe. Experience that the payer formularies require biological failure before switching. So we have to be educated. There has to be some education which should be done to all of the physicians about the concept and the use of biosimilar products. And now the guidelines has been starting to incorporate more biosimilars in their guidelines in their use. So the NCCN has started that, starting with the hematopoietic growth factors, and then for the breast cancer, for the trastuzumab. This is a very nice paper. If anybody wants to read about the biosimilar, it has been published in the GCO 2018 by Gary Lehman, the same guy in the New England Journal. He's the chair, the ASCO chair for the biosimilars. He is describing every single aspect about the concept of biosimilarity and interchangeability. So this is a very important slide, which all of the legislative committees should be aware of. We should not put a lot of strain on the pharmaceutical companies so that it will not, for the research. Of course, it's a very sensitive situation. You will not have to put a lot of constraints on the pharmaceutical companies so that they will be able to deliver cheaper drugs. The European experience is just very nice. It has been there since 2006, more than 10 years now, and they haven't actually identified any drug or rejected any drug up till now due to safety or lack of efficacy. There is a challenge. Actually, will biosimilars be accepted and utilized in the US and elsewhere? Will the biosimilars help reduce the unsustainable increase in the health care? Will the biosimilar improve the patient access to a biological agent and reduce disparities in cancer treatment? Only time will tell. But also the European experience, this is the projected that it will save around 100 billion for the use of biosimilar in EU and US, even for just 8 products. And as you can see here, this is the European experience. The curve on the downside that you can see is the use of G-CSF or the filgrastim, the originator one. And since the introduction of the lower curve, as you can see, the introduction of the biosimilars, the use of the originator started to decline, and then the use of the biosimilars starting to rise up and lessening the costs of the healthcare. So biosimilarity or the use of biosimilar, of course, it can do a lot of advantages from additional options at lower cost and saving efficiencies, but the whole claim is that it has to increase access to biologics, lead to faster innovation and better health outcomes. And thank you.
Thank you very much, Professor Shazli, for this very nice presentation. And we hope biosimilars are available in our countries so that every oncology patient can receive his appropriate therapy. We hope. Any questions for Professor Shazli? So we now come to the end of the session. I would like to thank our guest professors for sharing and for participating as speakers in this session. I would like to thank the organizing committee headed by Professor Shadi for inviting all of us for this excellent meeting, and thank all the audience for their patience and their presence until this time. The dinner will be at 8 in the main restaurant of the hotel, inshallah. Thank you very much.